Hello, my name is Professor Stuart Harris, and today I'm joined by Dr. Anders Carlson and Professor Shannon Itzik for this discussion on overcoming barriers to continuous glucose monitoring in type 2 diabetes to optimize outcomes. So why should CGM be considered for patients with type 2 diabetes? That's the key question that we're going to address today. Well, if we go to the old standard, hemoglobin A1C, hemoglobin A1C does not provide the full picture of an individual's glucose profile. Here are three hypothetical patients who have the same A1C, and yet what you can see is tremendous variability between all three. And we know that different glycemic patterns can be associated with the same A1C. We know that hypoglycemia drags the A1C down, and of course hyperglycemia up, but it can appear as an overall average. And also that hemoglobin A1C is not a reliable predictor of hypoglycemia. So there is this J curve with hemoglobin A1C where you can get hypoglycemia both at high A1Cs and low A1Cs. And finally, it's difficult for clinicians to treat type 2 diabetes based on hemoglobin A1C alone. We did that for many, many years, but we have new technology that gives us much more insight based on CGM readings, and that's what we're going to get into today. It's really important to understand what CGM measures, whether it's measuring glucose in the interstitial fluid or in capillary blood glucose. And this slide really depicts that capillary blood glucose is measured in the capillary blood, absorbed from the skin by a test strip, and that is different than what's measured in glucose in the interstitium, which is what a CGM sensor tip measures. There are a wide range of CGM sensors for use in type 2 diabetes. This is what's available today, for example, in the United States, but there is much more advancement coming. It's a very hot area of development. So CGM is here to stay and getting better and better as time goes by. So at this point, why don't we bring in our two panelists to talk about questions that have been pre-canvassed from our target audience to kind of elucidate some of the more details around CGM and its appropriate use in type 2 diabetes. So Anders, do you want to talk about what the guidelines say around CGM use in patients with type 2 diabetes and how it applies to everyday practice?
Sure. There's a variety of guidelines out there, and they sort of vary by region. But here in the U.S., the American Diabetes Association recommends CGM for all adults on insulin therapy and adolescents on intensive insulin therapy, so multiple daily injections or pump therapy. Now, it'll depend by region, their access to CGM, cost, and other factors that go into it. But by and large, what we're starting to see is this idea that CGM is not just restricted to individuals living with type 1 diabetes or individuals on intensive insulin therapy. Really, it's a tool that can be used by a wide variety of individuals living with diabetes, including those with type 2 diabetes. Now, the idea of time and range as a target is also here to stay. There's a consensus among the international community that a time in range of 70 to 180 milligrams per deciliter or 3.9 to 10 millimole per liter is the recommended target. And the aim is to have individuals spend at least 70% time in that range. Now, of course, those targets need to be individualized. And that's just one of those really unique and beneficial things of CGM is that allowance for us to personalize our glycemic targets.
So is there, if you want to just continue on, is there any recent clinical or real-world data to support the use of CGM in type 2? Do you want to talk to that maybe, Shannon, a little bit?
Sure. So there is, there's been tons of research done on continuous glucose monitoring. There was a recent meta-analysis looking at real-world studies and the improvement in hemoglobin A1C, which is more than 0.5 percentage points just with the implementation of continuous glucose monitoring. There's also tons of of clinical data looking at randomized controlled trials in patients who have type 2 diabetes who are on insulin, certainly showing a greater reduction in hemoglobin A1C, an improved time in range, and less time with substantive hyperglycemia, where blood glucose is greater than 250, and that's in comparison to using blood glucose monitoring. So research on that. There's also multiple studies out there in patients, not just on insulin, but also on patients who are on oral agents.
And can I add to that? I attended a session at ADA, fascinating, important study of over 16,000 individuals from a claims database. And patients were either on no insulin, basal insulin, or multiple daily injections. And no matter which one you were, which group you fell into, the A1C was reduced by almost 1%. And just a huge number of individuals. So it's I think we're, as you said, we're really starting to see the evidence mount.
What is the impact CGM has on patients' quality of life and lifestyle? I mean, what do you see in your practice? And I'll get both of you to answer this based on your own clinical experience, but I'll start with you, Shanna.
What I find is some of the challenges that we face in patients with diabetes, for example, fear of hypoglycemia or a lack of understanding of the food choices or exercise choices that they make, are really improved by having continuous glucose monitoring, because it allows them to see the impact of those either medications or lifestyle decisions on their blood glucose. And I, had a patient the other day who immediately when I met with him, I could tell that he had a concern about hypoglycemia. This was the first time I was meeting with the patient. The patient was on insulin, unfortunately on, other agents that were probably impacting his glucose as well, had been sent from a primary care provider, was on insulin as well as sulfonylureas, and mealtime insulin was an interesting combination of medications actually, but maybe not an appropriate combination of medicines, and was causing hypoglycemia. And he began to recant a story about how he had been in the barbershop and had to receive care from the barber because he became hypoglycemic while he was getting his hair cut. And the patient had declined to get his blood glucose checked in the office. He had mentioned that he knew it was going to be high and he didn't want to have it checked. So we had a conversation about how even if you're not checking it, it's still high. Not knowing the data is not necessarily helpful. So we talked about continuous glucose monitoring, and he was so excited about having the ability to do that without having to, one, check his blood sugar, and two, knowing that he could set alarms that would let him know he was going to become hypoglycemic before he required support from other people. Obviously, we made some medication changes as well, but that's, to me, a perfect example of how impactful CGM can be on someone's life, and help them make decisions and help us make decisions about what the right thing is for their care.
I've seen many patients where they come back after starting CGM and say things like, I had no idea that this type of food was affecting my blood glucose this much. If I had known that, this meal that I typically eat was making me spike so high, I would change my portion size or maybe avoid it altogether. And so I think it's empowering to patients to kind of see that, get that real-time feedback on their diet and their activity and stress. And the CGM gives us sort of qualitative and objective data. With CGM, you can sit down with the patient and say, I'm looking at yesterday, here's what happened to your glucose, tell me about your day. And it sort of takes that that burden off the patient of recollection, and is the physician going to judge me for my behavior, because it's just objective data, and there's really no judgment in that. So I think it really helps solidify our relationship as well.
So Anders, members of the audience have asked a question about additional benefits of CGM for not just patients taking insulin, but those just taking oral anti-diabetic or GLP-1 RA-based drugs. Have you seen this, and what's your belief about this?
Yeah, definitely. This is really an area that is rapidly expanding, both in terms of clinical practice, and also the evidence is mounting that there is a benefit of CGM in non-insulin therapies, and particularly GLP-1. I think the use of CGM there is not so much mitigating hypoglycemia the way we traditionally think of it for patients on insulin, but rather helping the patient as a tool to identify patterns and identify certain lifestyle decisions and behaviors that impact their glucose. The other piece of it that is really helpful is for us on the clinician side for the sort of retrospective review of how that patient has been doing. So when we meet with them, periodically, we can kind of zoom out and take a high level look at their patterns. Are they trending high in the evening? Should we make some discussion points around their dinner choices? And that is something we never would have identified just based on an A1C, but it does impact their overall glycemia. And so we can leverage CGM as sort of a retrospective tool as well.
Those are great points. I mean, and I think that the evidence, as you suggested, is really growing fast, which is going to push guidelines to move beyond just recommendation around insulin therapy and CGM use into a much broader application in type 2 diabetes, as you mentioned as well, Shannon, in prediabetes as well.
Yes. The other thing I think would be remiss not to mention is that, there are certain subsets of patients who have pretty substantive hypoglycemia on oral anti-diabetic drugs, particularly sulfonylureas. And I do think it's helpful in that population of patients. It may help us decide on different agents for particular patients, but also, there are other groups of patients that do have hypoglycemia and can benefit from CGM for those reasons as well.
So, where do you think it's heading in terms of, as I mentioned at the outset, there's a lot of evolution and new developments. I hear rumors that there may be a ketone measurement as part of the sensor to measure ketones. Do you expect, where do you think this is going? And I can start with you, Anders, and then you can chime in afterward, Shannon.
Sure, I think you're absolutely right. I think this is a growing area for sure, and I think what we're going to see is, those who are struggling with their diabetes, high A1Cs, despite multiple attempts at intervening. I think this is an excellent opportunity to leverage the benefit of technology and not just reserve it for those with the lower A1Cs who, have been tracking their diabetes very closely. But I think you're right too. We're going to see, more wearables and how, glucose or ketones feed into those will be interesting to see. I also think we're going to see CGM used more for guidance of lifestyle and diet more than just tracking the glucose. So integrating it into recommendations around nutrition and healthy eating and healthy lifestyle as well.
Absolutely. I'm often reminded of, the cost of televisions and how much they've gone down over mass use over the past, however many years, and what I paid for a plasma screen, 20 years ago versus now. And I think we're going to see the same thing with continuous glucose monitoring as it becomes more mainstream. And in particular, as we start to look at those that may be over-the-counter, patient purchased for patients who don't even have type 2 diabetes, that are just interested in how their nutrition impacts their blood glucose.
That's a great conversation, a great discussion. I thank you both for your insightful comments, and I'm hoping the audience will take away some key practical tips out of this. Hello, my name is Professor Stuart Harris, and today I'm joined by Dr. Anders Carlson and Professor Shannon Itzik for this discussion on overcoming barriers to continuous glucose monitoring in type 2 diabetes to optimize outcomes. What we're going to focus on in this section is how can we increase uptake of CGM in patients with type 2 diabetes, and especially in the primary care setting. Well, we know that there are multiple barriers to CGM uptake in type 2 diabetes, and I'm just going to flash a bunch of different comments, quotations that have been taken from interviews with providers and patients around awareness, time in consultations, and I think this is a big issue, particularly in primary care, where they feel that it's more time-consuming, when in fact, once you get used to using it, and I'm sure my panelists will agree, it's actually very time-saving and efficient and facilitate a much more powerful clinical encounter. There's concerns around the technology. Is it too much? Is it too difficult? Trying to understand the interpretation of the reports. The cost, of course, is an issue or a barrier for some individuals at the patient and system level. And finally, implementation challenges, which I think there's still a lot of work that needs to be done to facilitate better uptake, especially, as I mentioned, in primary care. So the following questions have been pre-canvassed from our target audience. And I'll start maybe with you, Shannon. How do you identify which patients CGM would benefit the most, and who should they be referred to help them with the setup? Are there patients with type 2 diabetes for which CGM is also unsuitable for?
So, I really personally believe that the majority of patients with diabetes should be offered CGM. Now, that does not mean that every one can afford it or that their insurance will cover it, but I really first start with anybody who's on insulin. So I think any patient who's on insulin should be offered continuous glucose monitoring because the risk of hypoglycemia, and in particular, anyone who is on any type of basal bolus therapy where they're taking mealtime insulin. I think, patients who have a high risk of hypoglycemia, even if they're not on insulin, it should be considered. In particular, anybody who's had hypoglycemia or, the type of hypoglycemia that requires support from other people to correct really should be offered continuous glucose monitoring. Are there patients with type 2 diabetes that it's unsuitable for? And that's probably could be controversial, but the patients that I might consider it less on are those who really just can't overcome the technology challenges. But I do find that patients who struggle initially with a technology challenge, with education, can almost always overcome those technology challenges because the devices really are rather simple. And with some education, most people can overcome them. In terms of, who's going to teach them those things, obviously there's a variety of people that we employ, in practices that can help patients with the technology, whether it's a diabetes educator, a pharmacist is another example. Even in some primary care practices, the medical assistants can, with proper training, can educate patients on how to get the app set up, how to insert the device, et cetera. So I think working with patients to overcome those technology challenges is really the most important.
Yeah, I completely agree. And I think, sometimes when there's a patient that you feel strongly or would typically recommend CGM for, but they, don't necessarily think it's going to be useful or appropriate for them, that's an opportunity to use professional CGM. And that can be really helpful, either blinded or unblinded, to show the patient, here's your data. Would this data be helpful to you? Would you find this useful? Or is this just overwhelming and something that just adds to the burden of your diabetes?
And I think also the bias that perhaps providers have, presuming that certain individuals would not suit them. And I think, what comes to mind most obviously are elderly, where in fact it can be a hugely supportive tool that family members can thereby have better understanding, as well as the elderly individual. The next question deals with the analysis and the interpretation of the CGM reports. And I'll hand this one over to you, Anders. Maybe you could walk us through what does an AGP report look like?
Sure. The AGP is the ambulatory glucose profile, and it's designed to be a standardized way to interpret and view glucose data, either from a CGM or a capillary glucose monitor. But what we want to do with an AGP is really make it something that's quick, easy to understand, and actionable in a very short period of time. And it needs to be something that both the clinicians and the patients can rapidly digest, identify patterns, and come up with an intervention or an action plan. So the AGP is broken down into three parts. The top part here is the time and range metrics. So on the left hand side, you have the thermometer of time in range, above range, and time below range. And on the right-hand side, some information about the activity of the CGM, the dates, as well as average glucose, the GMI or glucose management indicator, which is a rough estimate of a hemoglobin A1C based on the CGM data, and also the glucose variability marker given as a coefficient of variation there at the bottom. So that can give you an idea of the patient's sort of overall glucose. Now, if you look in the middle at the profile, this will show you a daily modal view of 24 hours of those 14 days or whatever is incorporated into your report put on top of each other. And so this is where you look for patterns of hypoglycemia as well as hyperglycemia and variability throughout the day. So in this individual, for instance, you can see that you can very readily see that they have hypoglycemia overnight, followed by hyperglycemia in the afternoon, and even more so in the evening. And so this would be an individual, for instance, who possibly is on a sulfonylurea or on basal insulin, and those medications should probably be reevaluated and adjusted to eliminate or reduce that hypoglycemia as much as possible. So just one other tool there to see the patterns. And then if you want to drill down deeper, you can look at the daily profiles. And this is where it's helpful to ask a patient about a given day or about patterns that they see, and you can kind of highlight are days that you work different than days you don't work? Is a weekend different than a weekday, and so on. I think it's important for clinicians to take a little bit of time to get used to this interpretation in a structured and a systematic way that will, number one, make them more comfortable with it. Number two, make it a little bit easier to frame the discussion with the patients. And number three, save time for them as they come up with the action plans. They can kind of identify those things really quickly and say, this is what we're going to focus on now.
Shannon, I'm going to put you on the spot. What do you think? Is it time consuming or time saving?
So I do think over time, it's time saving. I think back to all of the times when patients would bring me their handwritten glucose logs, and I was looking at them trying to average things or trying to take their BLD where they had written breakfast, lunch, and dinner and quickly do some kind of computation to figure out, is it low in the morning or is it high in the morning or when is it high? And then really having zero idea what it was in the middle of the night, trying to guess that their morning hyperglycemia was a result of nighttime hypoglycemia. So I think it's doing the math for us, right? So, and now it's just automatically there all the time. It's even there when the patient's not in front of us. So I do think it's tremendously time saving, particular once it's started up and moving along.
Shannon, what do you find is the simplest way to explain the concept of CGM to your patients, which in turn, will hopefully help improve their understanding of the technology and its usefulness in achieving glycemic control and everyday management of diabetes?
So, I think what I really explained to them that, when they check their blood sugar, that's that one point in time, right? It's that one moment. And, for patients who have a hard time understanding, sometimes I'll explain it to them like their bank account. Like, if you were to look at your bank account today, you might have X amount of money, but that doesn't tell us what you had yesterday or the day before or before you got your paycheck. So it really tells us that's what CGM does. It tells us what it is all the time, as opposed to that one point in time. It constantly monitors it. CGM is a pain-free device that we apply to your skin, and it monitors your glucose all the time. They do have lots of questions though, right? They want to know, does it hurt to put on? Does it hurt when it's on me? Do I put it on? When do I take it off? So, we go through some of those questions, but I do find that most patients understand the concept of that continuous monitoring.
So, Shannon, is there evidence that although there is this upfront cost, is it cost saving particularly to the system?
Yes. So I think when we look at the evidence, it does say that there is an upfront cost, right? But there have been multiple studies on the cost effectiveness in CGM across the globe. There was a US study that looked at use of real-time CGM and rates of diabetes complications, and it was found to, suggest long-term cost savings benefits. Italian studies, which showed that while the acquisition costs up front are higher, which we can understand and expect, that over time, due to decreasing complications, that it was cost effective. Again, other studies in Japan, again, showing some increase in costs with certain things, including cost of insulin therapy, but decreasing cost over 20 years. So increased costs maybe to therapy and dialysis, but decreased costs when we look at microalbuminuria, end-stage renal disease, and cardiovascular disease. So I think, when you think about the technology again, as the cost of the technology decreases, which we fully expect it to do, it will be an overall win.
Recently, just this past ADA, I presented an overview on healthcare utilization and use of CGM and demonstrated consistently reduction in ER visits and hospitalizations, especially with adverse diabetes events. And I think that in part is what's driving now cost-effective models that are demonstrating it as cost-effectiveness. Finally, I just want to touch on this issue around barriers, socioeconomic status. Is it too sophisticated across different socioeconomic strata? Anders, do you want to start on this and what your opinion on it? And then I'll ask Shannon to chime in as well.
Yeah, this is a really important question, and I think something I'm glad this was brought up. Going back to the first question that you asked about, how do you identify patients who would benefit the most? I often approach it as from the opposite end and come into the room and say, what are the reasons why I would not offer this technology to this patient? And I try to frame it that way. And I find that makes me offer it to more individuals or consider it more readily for them. And I think with the technology evolving, what we're seeing is not only are the CGMs are getting more sophisticated, which is good for those who need it, but we're also seeing some of them become more simple and that maybe they don't need all of the bells and whistles and alarms and features that the other systems do. We just need it to do kind of the bare minimum glucose monitoring, which is so helpful to us. So I think it's going to be an incredibly powerful tool.
And hopefully we're going to see better access, particularly to those more vulnerable populations that traditionally have many barriers, not just access to technology, but to healthcare in general and newer and better therapies. So thank you both for your insightful comments. Thank you for your time. Hello, my name is Professor Stuart Harris, and today I am joined by Dr. Anders Carlson and Professor Shannon Itzik for this discussion on overcoming barriers to continuous glucose monitoring in type 2 diabetes to optimize outcomes. So in this portion, we're going to focus on how can we best support patients undertaking CGM. And the best way to perhaps present this is use a patient case study. So here's our case. He's a 62-year-old man diagnosed with type 2 diabetes 10 years ago, overweight, but currently no relevant comorbidities. He's managing his type 2 diabetes with oral agents as well as basal insulin, and his most recent A1C reading was 8.5%. He does experience hypoglycemia to the point where he now has hypoglycemia unawareness, and he is not aware of it until his values are quite low. From a personal perspective, he lives 50 miles away from the nearest diabetes clinic, has a manual job, so regular finger prick testing is inconvenient. He does not find it easy to use technology and only uses his smartphone for calls and messages. He's unsure how to adapt his lifestyle in response to his hemoglobin A1C readings, and in particular to his recurrent hypoglycemias. With this patient presentation, I'm going to turn it over to the panel for discussion on how would you support this patient to integrate CGM management and his type 2 diabetes. So let me start off with you, Shannon. How can primary care physicians, and these are based on questions pre-canvassed from our target audience, how can primary physicians, diabetes specialist physicians, pharmacists, allied health workers like nurses and diabetes educators all collaborate ideally to best support patients who are using CGM? And do you find patient support programs useful to support individuals undertaking using CGM?
So, I think thinking back to this particular patient and the fact that he lives 50 miles away from, the nearest diabetes program makes his situation a little bit more challenging. But I think broadly, and that is not unusual. It's not unusual in the US. It's probably not unusual across the globe. So if we have access to those, they're amazingly helpful. I think getting patients to those centers where the full diabetes education program can be offered, and then in particular, focusing on starting CGM would be particularly helpful for this gentleman. I think one of the things that's very helpful for me in terms of primary care is the reminders about billing for this work. And I think sometimes clinicians don't know that they can bill for it. And so they see it really as a burden. It's something that just prolongs the visit time. And I think helping clinicians understand that allows them then to perform this service on their own. And they may have, other people in their office who are doing that work. They may have a registered nurse in their practice who can do the education and show the patient how to do it, a medical assistant. They don't actually have to do it, but they can bill for it. So I think that's really important. I think if they have access to a diabetes education program, they should 100% be sent there. I think every patient would benefit from diabetes self-management education. But in light of not having access to it, like this gentleman, that we may find that the clinician needs to do it and should then be able to bill for it, for their work.
I think we're starting to see a little bit of a paradigm shift in how we structure diabetes care, particularly in primary care, where we'd ideally see this. But what you can imagine is, especially thinking about this patient, if he were able to remotely download his CGM, we could review that in the clinic. We could set up a very brief visit with him monthly or every other month. He wouldn't have to leave work or take time off. He could do it over his break, and we could just look at the data really quickly and make a couple action plans, and then meet back frequently, rather than having him take a whole day off of work and come in quarterly, where we lose a lot of opportunity to intensify or de-intensify his care. So I think CGM really allows us to think about how we conduct diabetes visits differently.
And for me, with this particular patient profile, his hypoglycemia unawareness is a real red alert that he's actually at much higher risk for severe hypoglycemia, maybe while he's at work, which of course will irrevocably change his life. So I think being aware of these hypos that he's not aware of through CGM reports is going to be really, really important and impactful. I mean, in our clinic, we do remote phone follow-ups where we have the reports for people who have challenges in getting into clinic, and we find it really useful. What about for older patients, if let's say he was 10 years older, or those with low technological literacy? Where do you think CGM interpretation comes in?
Sure. So I think early on, at our first visit, I do like to set aside a little bit extra time just to explain the data and what we're looking at, because for so many of these patients, they've been told that A1C is the best marker of their diabetes, and I want to get this idea of time in range and understanding where a glucose should be to keep them safe and healthy. So I spend a little bit of time on that. Of course, that discussion gets tailored depending on the individual, and I don't want to add distress to them by showing them all the different alarms and alerts and tricks to the device. But I think it's important for them to be able to react in real time, and to use the trend arrows, where the glucose is, where it's been. And I think, for older patients or those with lower technology literacy, we sort of start with reassurance and just kind of get them comfortable using it. And I tend to follow them more closely. But again, switching to that, model where we can conduct visits every month or every few weeks, where I can review it remotely after a week of onboarding. I find that that's really, really helpful. And I try to drive home the idea of being curious, rather than judging, having the patient judge themselves. Oh, I went to, 250 milligrams per deciliter after I ate that thing, now you know, and just kind of try finding things that don't make it go that high, because I think we really want this to be a tool that reduces the burden of diabetes rather than adds to it.
So I'd like to ask both Anders and Shannon around some of the practical issues in everyday practice that patients bring up, the wearability, should they be doing capillary blood glucose testing and sensor glucose measurement. Anders, you want to start? You're nodding.
Sure. I would say, I think this is where the diabetes education specialists are so key, like Shannon mentioned. So if they have, if we can get a patient in with an educator, I think that's so key. If not, then the manufacturer has materials to help troubleshoot on their, typically on their website, or there's plenty of, the diabetes community is really active. So there's some great patient-centered organizations that have wonderful materials. As for the finger sticks, I usually discourage patients from checking a finger stick glucose at the same time, just out of curiosity, because I think that can lead to distrust of both devices and kind of distrust of the whole management program. But I do recommend, if the CGM is not following their symptoms, if their CGM is reading really low or really high and they feel fine, or vice versa, then I think confirming with the finger stick can be beneficial.
Yes, I'll tell you, I think all of these companies have patient resource programs, and I find them to be very helpful for patients. I do try to tell them, because I find that patients invariably will check their blood glucose. That's what we've been telling them to do for years, and they will. So I try to explain to them the readings will be different for a variety of reasons. So don't expect them to be the same. They're not going to be the same. But I do think it's important, if they're having problems, that they would revert back to blood glucose if they're having symptoms that are unexplained.
Shannon, I think you're a great panelist to answer this last question here around how CGM data can be used to empower patients to making beneficial changes. Do you want to explore that a bit?
Yes, I think that's probably the most powerful part of CGM, is that patients can see their blood glucose real time. And, many of us have spent years working in diabetes, and I could probably look at a plate of food and tell you how, all of the nutrients in it, including carbs, and how long they're going to act or react on a particular patient. But we also know that not every patient's the same. I think, as Anders mentioned, particularly dietary decisions that they make, that I really think patients just don't have a good comprehension of. I had a patient who came to me and said, "Oh my gosh, I was running around and I thought I would go through a drive-through and get something that I thought was healthy for me." They actually got chicken nuggets from somewhere. And they thought, wow, that's just meat. It's not really going to have a big impact on my blood glucose. But now I realize that they're really soaked in sugar and they're coated in sugar. And holy cow, did it really make a difference in my blood glucose? And I'm never eating that again. They really can see the impact of these decisions. They can also then see the positive things, right? When they eat a well-balanced meal, how it doesn't spike their blood glucose. So it really helps patients be able to see the impact of the things that they're doing and again, and also some medications, right? So when I take the right amount of insulin with the meal, or when I don't underestimate or I overestimate what happens, it really allows them to see those things.
Well, and to me also, we talk about the importance of education around diabetes, and often when people are diagnosed, they get that package of education, what is diabetes, et cetera, and that's kind of it. But I find with CGM, it's like lifelong education. It allows that continuous ongoing education as their life circumstances changes, their diabetes, their medications changes, their work environment, like the case example we talked about, and it allows us to reinforce. I think that was a great example around the chicken nuggets. And you thought that was healthy. Turned out your body's not so keen and happy with it. And look, you could never have educated someone, say, stay away from chicken nuggets. but in fact, when they see it themselves, they're empowered to make those personal decisions. So I think that was a great conversation. So thank you to Dr. Anders Carlson and Professor Shanna Itzik for joining this discussion on optimizing the continuous glucose monitoring use in type 2 diabetes. I really want to thank our audience for watching, and hopefully it's been educational and useful to you. And most importantly, I hope you're going to have a better and greater enthusiasm to start incorporating CGM use into your everyday practice in individuals with type 2 diabetes. Thank you very much.